I know many of you share my thoughts. I've never in my life seen so many people work so hard to prevent a law from actually helping people that was designed to do that. So we thought it was way past time that we have a crucial conversation and hear from an expert about what the law actually does, who it helps, and why it's so important to millions of people across the country and in North Carolina. So thank you very much for coming. We hope to have a lot of these crucial conversations in 2014, and we hope to see you all back. And with that, I'll turn it over to Rob Schofield.
And I'll just say that I have my own little anecdote from some media work that I do, where I appear on a conservative talk show on Friday afternoons, and the host has been making a big deal recently about the fact that his daughter just couldn't get coverage, was having real trouble finding coverage under the Affordable Care Act. And then I went on the show last Friday and I said, how's it going? Because Adam Searing from our Health Access Coalition had actually gone on the show and made an offer of call us, we'll help her get signed up. I said, well, how's it going with your daughter? And he said, well, you know, she did get a policy, but it's costing her $300 a month, and before she was only paying $100 a month. And I said, $100? She must have had a real sort of a junk policy. What was the deal there? And then he said, well, as a matter of fact, it was only covering her child. It wasn't covering her. So it turns out that she was uninsured. And now her family's got $300 a month health coverage. So there's a lot of misinformation out there on the Affordable Care Act and the realities. It's not to say, we're all here to readily concede that the Affordable Care Act is far from perfect. It would have been nice if we could have worked together as a government, as a society, to really find these solutions together and make it work. But so be it as it may, we're going to plow ahead with it. So today we've got two wonderful experts to help get us up to speed on it. Adam Searing, as I was referencing, the director of the North Carolina Health Access Coalition project at the Justice Center, my colleague for many years, is going to give you just a couple minutes on what's going on in North Carolina. And then Lynn Quincy from Consumers Union is the star of our show today. Lynn, I've got it written down here, works on a wide variety of health policies at CU, focusing primarily on the areas of consumer protection and health insurance reform at the federal and state levels. In addition, she serves as a consumer representative with the National Association of Insurance Commissioners. And prior to joining Consumers Union, Lynn was a senior researcher with Mathematica Policy Research Incorporated, where she performed policy analysis, provided technical assistance, and modeled outcomes in support of state coverage expansion strategies. She's worked with state level advocates for many years. So she's a real knowledgeable expert on this subject, and we're delighted to have her come down here and risk her life by flying back in the snowstorm this afternoon to Washington. Anyway, Adam, why don't you come forward and offer a few remarks, and then we'll hear from Lynn.
All right, and thanks, Rob. And I'm really excited to have Lynn here. She actually is a colleague with Adam Linker, the other Adam who many of you know, as Rob was saying, about at the National Association of Insurance Commissioners, where she and Adam are one of just a few consumer representatives in a sea of every insurance company and insurer and agent that you can think of, all trying to get the insurance commissioners to write laws and policy that favor industry, and Lynn and Adam are out there saying, let's think of the consumer. So all I want to say very briefly, after our disappointing rollout of the Affordable Care Act, I do feel like we're turning the corner. And I was just in Roanoke Rapids on Saturday. Adam Linker was down in Pender County at James Front Community College. Nicole Dozier has been in Greensboro and out towards Chatham County recently. And we're all just in the last week or so hearing more and more stories of people who are signing up, whose websites are working. And things are starting to really go, and we're very obviously we're relieved, but we're seeing the impact that this can have. And I just want to tell you, I think one thing we miss when we have these discussions is the impact this is having on some of the poorest parts of our state. And Halifax County, where I was this weekend, is not a economic engine of North Carolina. It's probably either one of the poorest parts of our state. And when you talk to people who for the first time were able to sign up for health coverage and get something that many of us just assume is normal and that we always will have and that we have had. But when somebody who, in a community like that, is able to get something and be able to see the doctor for the, sometimes for the first time in years, it is the effect that it has on them, and when they tell you about it is just, it's amazing. And that happened to me this weekend, and I just can't, I just wanted to express to you how that personal impact, especially among places in our state where that need is great, is really, it's stunning. And so I want it to succeed, and I want to hear from Lynn about how it's going to.
And I want to say two more things by way of introduction before Lynn goes. One is I want to acknowledge State Senator Mike Woodard, who's from Durham, who's here joining us today. Thank you for joining us. And I think Representative Pricey Harrison is also registered for the event. We may see her shortly. I also want to call everyone's attention to the fact that one of our most senior and important consumer advocates in the state for many years, Dick Hatch of AARP, is celebrating his 85th birthday today. 85th. So with all that out of the way, let's hear from Lynn Quincy. Lynn, you're on. The show is yours. You can hit the advance switch on the computer to advance your slides, or I can do it for you.
All right. Can you hear me? Yes. Okay. I'm not sure why I use a microphone and nobody else does, but it will be revealed to me later. I'm really happy to be here. What a great group. Thank you for coming out early in the rain. And let's go ahead and get started. I was asked to kind of take a broad look at the Affordable Care Act, but if I didn't get it quite right, there's going to be a question and answer period, and we can talk more about it. Anything you want to talk about, fair game as far as I'm concerned. So, there we go. Okay, so I'm with Consumers Union, which is the policy and advocacy arm of Consumer Reports. Not everyone realizes that we do work in addition to testing your cars, but we have a whole arm designed to try to protect consumers in the marketplace by reviewing regulations. The National Association of Insurance Commissioners, as Adam explained, here are the numbers. He said the sea of health plans. When the National Association of Insurance Commissioners meet, there are 2,000 health insurance lobbyists, basically, in the room, and 10 consumer representatives. That's the C that he's talking about. So that's who I am. I love working there. It's a great organization. So I wanted to look backwards, and then I'm going to look forwards a little bit. And let's just get the Affordable Care Act. Let's get out of the present. Let's just talk about, why do we have this act? What are the problems this act is seeking to address? Well, some really important consumer issues. Inequitable access to health insurance coverage. Health insurance is your gateway to getting health care, as Adam was just explaining. If you don't have health insurance, you're very likely to be denied care that you need, and you can have pain, suffering, reduced quality of life. We all know that. I won't belabor it. We also have poorly functioning health insurance markets, and I want to talk a little bit about what the Affordable Care Act does to improve how those markets work. Consumers, and this is closely related, are not empowered to function in these markets, and the Affordable Care Act seeks to address that, but I'd actually like to work together to go a lot further. And a key problem that we all face is that the cost of health care is rising at unsustainable levels. It's actually the core of all of our other problems. If health insurance costs next to nothing, we wouldn't all be in this room today talking. So let's talk about the cost of health care, because this is at the core. You may have seen figures like this. The average cost of a hospital stay is $9,700. That seems pretty high, but maybe in the realm of what you might be able to pay. But in reality, if you have a specific illness and you add in all those other costs of lab and the anesthesiologist and the specialist and the surgeon and the drugs and the rehab, we're talking about money that almost no family can afford to pay out of pocket. That's why we need health insurance. I am a breast cancer survivor, and this is a realistic number. That's what it costs. The drugs associated with treating a certain type of breast cancer can run $70,000 just for the year. So we need health insurance. In fact, I would say that health insurance is a social good. Everybody should have access to it. It should not be based on whether or not you can afford it. I already made that point. The other reason why health insurance needs to be a social good is that we need to spread risk broadly. We all benefit if the insurance pool of people is large and includes everyone. So there's, we don't want little tiny boxes of people who are insured. We want a big pool of people spreading all that risk, the rarer risk of getting the breast cancer or the heart attack across our pool of people. It should be very broad. So what does the Affordable Care Act do to address that? Well, very shortly, what I call the key reforms or the act is huge. It's this huge, you've probably seen it, it's this enormous law. I actually have read probably the vast majority of it. But the key reforms that address the problems I just talked about are coming right up. On January 1st, 2014, you can no longer be denied coverage or charged more if you've been sick in the past. This is huge. This is huge. This is where we all want to get. In fact, very few people would argue that we don't want this outcome because it's the fair and equitable thing to do. Okay, that if you are ill, you still need health insurance. I still need health insurance. But we can't just, we already had some protections. They weren't broad enough. But the problem was, even if people had a right to coverage, they couldn't afford it. And now, there's another major reform which says, if you don't have access to Medicare, you don't have access to Medicaid without an important exception I'm sure you're all familiar with, and you don't have access to employer-sponsored coverage, we're going to help you pay for it if your income is less than 400% of federal poverty level. And my next slide will show you exactly what incomes we're talking about. And we also have some important reforms that make the market work better for consumers. Consumers Union has done tons and tons of work in this area, and I'm going to tell you about those. So who are we talking about? Well, the main target of reforms are these people who are uninsured now or who buy on their own. Because these folks over here, the biggest portion of the pie. Oh, so this is the distribution of the U.S. population by what your source of health insurance is. Not spending, just where are you enrolled, if anywhere. For the employer population, the message that many consumers on the ground don't really realize is not a whole lot has changed. There are some nice little benefits. I'll talk about one of them, tinkering around the edges, but for the most part, employer-sponsored insurance continues as it has before. Medicare, for the most part, continues as it has before. It's good, solid coverage that meets people's needs. Medicaid we'll talk about a little bit, but obviously it's not being rolled back. The question is just, is it being expanded? So 400% of the federal poverty level. These are the people who buy on their own that the new tax credits are designed to help, and I'll talk a little bit about those tax credits. But as you can see, this goes quite high up the income stream. But it needs to, because health insurance is very expensive. This is another message that's not widely understood, is the fact that people get help very high up the income stream. So this help takes the form of a new tax credit. And this is one of the least talked about aspects of the Affordable Care Act. So I hope you'll all go out and start talking about the tax credits. You can only get it if you don't have access to other forms of coverage, with an exception. Your income has to be less than 40% of federal poverty level. We just showed you what those income levels are. And it can only be used for coverage purchased through the marketplace. The marketplace used to be called the exchanges. This is the new healthcare.gov in North Carolina. You have to buy coverage offered through there, and then you can use the tax credits for this coverage. What you'll find in the healthcare.gov are private insurance plans, like Blue Cross Blue Shield of North Carolina. A big variety. They're good plans. They cover a comprehensive set of services. It's a pretty adequate coverage there is in there. Now, but this tax credit, the folks in this room are probably not put off too much by the term tax credits, but lots of Americans are. They're like, taxes are hard, health insurance is hard, I want to throw up my hands and give up. So we have a little bit of work to do to explain how they work, because these tax credits are a little bit different from other tax credits like your home mortgage deduction. First of all, you can get the tax credit in advance at the same time that you need to pay for health insurance. This is a huge help because we all know health insurance is expensive, there could be a cash flow problem there. So It is your option, but you can get the whole thing in advance and you just reconcile it when you pay your taxes at the end of the year. It goes right to the insurance company, so it's fairly simple logistically if you get it in advance. If you take it, if you just wait and get it when you file your taxes, it comes right to you in your refund. And if you choose to take it in advance, you'll get a statement, a little form like you're similar to your W-2 from the insurance company. You file it with your taxes and say, you know, here's how much tax credit I took in advance, and the IRS works it all out, or your tax preparer, at least in theory. So this is a little graphic representation of what I just talked about, because all this tax credit activity takes place over a long period of time. Here we are. As soon as healthcare.gov starts working, but we're enrolling. You can enroll all the way through March. Then you're covered through calendar year 2014. Then here you're paying your taxes in 2015 on your 2014 income, and this is where it all gets reconciled, because it is a tax credit, and so it works like anything else. How much money did you really make? What's the final determination of the amount of the tax credit? So this is how we help people pay for coverage if they're buying on their own. We did a little brochure designed to help explain this. It's the only consumer-tested, consumer-facing information that's out there. If anybody works directly with consumers and needs some information like that, at the end of my slideshow, I've got some sources, or presumably you'll have access to these after the fact. All right, so let's talk about, that's the new tax credits, how we help people afford. Let's talk about what makes the market work better. Buying health insurance is people dread shopping for health insurance. There's a survey out there, I did not sponsor this survey, that says they would rather go to the gym or pay their taxes than go shopping for health insurance. And this completely comports with my experience in trying to work with consumers, doing focus group work and so on. It's really hard. Buying health insurance for consumers is kind of like putting a blindfold on and saying, I'll take this $6,000 product over here without even seeing it. They don't understand, and the main thing that trips them up is the cost sharing provisions. They understand the premium, but how much coverage are they getting? What are the services that are covered? Consumers are worried about the fine print. Are there exceptions? It's difficult. There are lots of things in the Affordable Care Act that help consumers to be shoppers and to make the marketplace function better, not perfectly, but better, and I want to talk about that. One of the things you may have heard about are these metal tiers, which are also known as like the platinum, the gold, silver, bronze. These tiers, platinum is like the best. Well, wait, let me back up. These tiers give you a sense of how generous is the coverage, with platinum being the most generous and bronze being the least generous. We did a lot of testing around this, because this is also something like the tax credits, brand new for consumers. And these metal tiers really, in fact, let me go to my next slide for just a second. It's not in there. There it is. Sorry, I'm a little bit out of order here. These tiers provide a roadmap to consumers. It allows them to navigate their health insurance choices. If they know from credit cards in the Olympics, they know platinum's the best, gold is really good, and they will say things. All right, well, I'm going to start with the gold tier and look at plans in there, and they know that the amount of coverage they're getting is roughly the same. This is a huge help, because before they just had basically premium was the only signal that people had. So that helps them navigate the field. Forgive me, I'll go back up. There we go. We've standardized the scope of covered services. That's huge. You've heard it called the essential health benefits. It's a big comprehensive package. It's the standard across the state, and between states it can vary a little bit. But the basic idea is you can no longer buy a policy and find out after the fact it doesn't cover maternity or it doesn't cover drugs, because it's been standardized. And that's one less moving part that consumers have to worry about. There's an overall cap on patient out-of-pocket expenses, and this is also huge, because the out-of-pocket maximum, which is a signal to consumers the most they would have to pay, it used to be that it could be full of holes. There could be all these exceptions, and somebody did an amazing study that showed, sorry, there we go. Someone did an amazing study that compared several policies in great detail that appeared to be the same type of policy. They had similar deductibles, similar out-of-pocket maximums. But due to the exceptions in the poor policy, a consumer with breast cancer would have had to pay $20,000 more out of pocket. The devil was in the details in the old policies, and those details were basically not accessible to consumers. That has changed. This is a hard out-of-pocket cap, and you don't have to worry about that aspect of fine print anymore. Selective preventive benefits with no cost sharing, that's another form of standardization, one less moving part. It helps consumers. Something else that's really great that I'm going to spend a few minutes talking about is a new form called the Summary of Benefits and Coverage Form. Let's go right there. This is inside of the Affordable Care Act. This is another provision that very few people know about. Is a requirement that anybody shopping for private health insurance coverage, in fact, I got a little thing there, has access to a standard statement of what is covered. Before this standard, plans each had their own way of conveying what their plan covered to you, and you couldn't compare them apples to apples. Now we have this standard that you see behind here, and it goes across, it applies to grandfathered, non-grandfathered plans, exchange, non-exchange plans, employer plans, self-insured, every private plan you might want to buy. And this is fantastic. It means consumers can compare their marketplace coverage to non-marketplace coverage. Or if you have an employer option but you're thinking about buying on your own, that rare individual, you can compare those two plans. If two spouses both have a coverage offer from their respective employers, they can compare those plans on an apples-to-apples basis. Consumers could never do that before. But there's more. This is page 5 of this fairly long form. It needs some tweaking and design work. We did a lot of testing around this form. It was developed by the National Association of Insurance Commissioners. We seem to be plugging them today. And they were not going to do any consumer testing of this form. And we said, no, no, no. We went out and we tested this, the form, including this aspect. This is something that consumers have never seen before. It is, they call it a coverage example, and it shows what the plan would pay for a standard medical scenario like having a baby, treating breast cancer, etc. And it includes 3 things that consumers have never seen before. First of all, how expensive is medical care? You'll see the roughly $100,000 tag on breast cancer. Consumers don't know how much medical care costs. This is why in the old days, as I'll call them, they could buy a policy and maybe it had a $20,000 benefit limit. That was the most the policy would pay. That sounds like a lot of money to many people. And they were like, well, how could I possibly need more coverage than that? Because they don't understand how absolutely phenomenally expensive healthcare is. So it provides that type of information. Second, it gives the consumer a bottom line. All that stuff that they can't figure out, deductible, copay, coinsurance, it says, here it is. I did the math for you. I rolled it up. Here's a single number that they can use to compare across plans. Just like we take those miles per gallon stickers on cars and compare across cars because it was done in a standard way. But here is the unexpected thing. It also shows what the plan would pay. In this case, $94,000. Consumers never see that piece of information, and this was transformational. They said, oh my God, I bought the policy and then they paid all this money on my behalf, and they actually tend to forget that. I mean, they're not health insurance experts, they've got lives to lead, and to put that amount there, I had people in the testing flip from saying, I wouldn't buy this policy, it's too expensive, the coverage is terrible, I've got this $2,500 deductible. And they said, oh, but the plan pays on my behalf if I buy it. If I, it brought home a concept that they really were not keeping in mind when they shopped. Transformational. This is really, really big. Unfortunately, what I just showed you is not what they're looking at. This is what they see today. It's missing the breast cancer example. Health and Human Services, U.S. Health and Human Services, has promised, they saw the research both by Consumers Union and by health plans showing how important these examples were. And they've promised to do up to 6, but for now we just see 2 examples, and the absence of the expensive example is bad because that's the motivational one. We want it motivating. The other thing they did that I'm fussing at them about is they're using Medicare prices. Cost of having a baby was $10,000 when we tested it, now it's $7,500. That is not a realistic cost, it's too low. So some more, there's always negotiations, you know, well, we can all agree on Medicare. Well, it's misleading to consumers. So this is an example of a great policy that we need to do some tuning up with. All right, we talked about metal tiers. I want to talk about one other thing that makes the marketplace work. This is not directly in the Affordable Care Act, but it's similar to coverage examples in that it does the math for consumers. It gives them a highly evaluable bottom line that they can work with. In fact, I'll just go right to it. You probably can't see that, but this is the health plan shopping page or comparison page from Covered California, which did their own marketplace. And there's several things I like about it, but I'm only going to point out one part. It's providing something called total estimated cost, which is the combination of your premium, something that consumers understand, you know, they get the premium, but also an estimate of your out-of-pocket for the year. So it's an actuarial estimate that says if you were to buy this plan, you know, I know a couple things about you. I know your age and sex. You probably pay about this much out-of-pocket. They add those two things together, and you have a good solid basis for comparing health plans, because we don't want them relying on just premium, because it doesn't tell them how much coverage they're getting. So this is another example of how they've taken the flexibility in the Act in terms of how you convey health plan options to consumers and created the much better shopping experience. And I would like to see this type of information, which is not brand new. It's been used for federal workers in a tool called Consumer's Checkbook for years, so we have a lot of experience with it. It really helps consumers by, again, rolling everything up, giving them a bottom line, a summary measure, or sometimes people call it a cognitive shortcut. It's reducing the cognitive load of comparing what is really a complex product. So, that was my section on what does the Affordable Care Act do about these problems? And obviously, just skimming the surface. So, but now let's look back, let's look forward. We've really survived a lot. This has been really tough. Does anybody remember Scott Brown and his truck? And everybody liked the fact that he drove his truck around the state of Massachusetts. He came to the Senate, and suddenly it looked like we didn't have the votes to pass this law. And we squeaked it through. Obviously, the Supreme Court had, it survived the Supreme Court. It was a little hard on Medicaid, but I think we can overcome that. We survived the elections, and now the faulty rollout of healthcare.gov and all the brouhaha about the cancellation letters. But we did it. Now let's look ahead, as Adam pre-staged me. When people can finally see this new coverage and enroll in it, for the most part, they like it. They're surprised, they're happy, they're like, I didn't know the law did this. They just had no concept of what was in this law and what it meant for them at the end of the day. But there's lots more to do. I wasn't going to let you off the hook. I hope you know that. A big one affecting your fair state is there's a group of people who don't yet have a coverage option. If you are not eligible for Medicaid in today's world and you are below poverty, you have been left holding the bag. You don't have a coverage option. Those tax credits I was describing can't go below poverty, except for one group of people. Recent legal immigrants can get the tax credit because it wasn't expected they would have a Medicaid option, so something had to be done for them. So this is the big hole in our coverage group, but just so you don't lose, or in terms of getting folks into coverage, all right, never mind. Okay, so I'm sure you've seen some of these statistics. When states expand Medicaid, really good things happen. Obviously, we understand folks gain access to coverage, the coverage that pays for those very expensive healthcare treatments that we just talked about, without which they are not going to get the care we need. I mean, it's unambiguous. But you also create new jobs. This was a study, I've got the source down at the bottom, and this study just looked at the direct effect of expanding Medicaid, but studies I've seen for other states also incorporated what they call the multiplier effect. As soon as, Joe Smith gets a job, he now has more money, he goes and he spends it, and that creates an economic boost that multiplies throughout the state. And in the shorter run, it actually saves the state money to expand Medicaid. Well, why is that? Because the federal government is paying all the costs for the expansion population through 17, 18, I forget, in the early years. And what?
For the first 3.
For the first 3 years, so through 2017. And they have more tax revenue coming in from this economic expansion. And people have studied all this stuff and said, oh, look, there's a net savings. Now, this does not perpetuate over time. Eventually, there is a small outlay, but that small outlay, and are you going to talk about that, the Commonwealth report?
Yeah,
Back up? Okay. There's a small outlay that into the future, but that small outlay attracts millions and millions of federal dollars. Without the expansion, North Carolinians are contributing through their federal income tax to the pot of money that helps expand Medicaid in other states, because again, this is federal money, and they're not realizing the benefits. And I'm sure we don't want that. And they're still incurring costs for emergency care for this population without coverage.
Is there any kind of study on that second item? I mean, any kind of
The cost?
Yeah.
Well, specific to North Carolina, I'm going to defer to Adam.
Yeah, no, the Institute of Medicine and our state DHHS looked at that, and in fact, when you expand, because the federal money comes in and takes over the costs of both for uninsured people who would get Medicaid. So right now, the state governments and county governments pay a lot of costs for emergency care for people in ERs. They pay a lot of costs for mental health coverage, and so all those costs are now, either all or 90% borne by the federal government. So we end up saving money. So they look specifically at that saving.
I mean, you just never see that in any articles. Or
You're saying, what's the tabulation of this?
Yeah.
What are the
I mean,
dollars?
here's one side
Yeah.
of the equation. You've given us the one side. What's
Yeah.
the other side? It's
Yeah.
like the whack-a-mole thing.
Yeah.
If you don't have this, you still have the cost comes up somewhere. These people don't disappear and don't
Yeah.
get any care.
I've definitely seen state-specific estimates to that, but I don't know what the number is for North Carolina, and maybe we can.
Well, it's we save over time. Like the first 2 years, we saved $150 million in the state because those costs are covered.
I mean, it just seems like you need one of those
Yeah.
things like with the deficit that shows minus plus.
Yeah. Well, definitely. I mean, it could be laid out very nicely, but I wasn't allowed to talk about Medicaid the whole time.
Yeah, we can talk about that all.
But I think there's reason for hope. We're still talking about Medicaid. You may not realize this, but when Medicaid was first introduced in 1965, not every state got on board, and the last state, Arizona, didn't actually take those federal dollars and do their own little brand of Medicaid until 1982. And S-CHIP for shorter time frame, but the same thing. It takes a while to ramp up, and if you're one of the last states to expand coverage for kids, it got a little embarrassing. I think actually with Washington and Hawaii, it was that they had a similar coverage program, but I know that there were some latecomers that the pressure really mounted when they became one of the few states that was not yet covering their kids. So let's hope we'll play out in a similar fashion. All right. Now, what I consider actually to be a lot more challenging is dealing with this issue of the affordability of health insurance and of health care, because of course forget all the rhetoric you're hearing about, taxes, fees, now maternity's in there and I'm never going to be pregnant. The problem, why health insurance is so expensive, is that the underlying cost of health care is so high. I mean, this is the big reason that we pay absolutely enormous premiums. But here's some important concepts as we think about this difficult issue. First of all, affordability is in the eye of the beholder. If you're someone who was uninsured and is just hanging on until January 1st till your coverage can start because you have some illness that requires drugs, or you're like, I'll pay any premium, just get me the health insurance coverage I need. And for those people, health insurance is affordable. There's a lot of them out there. Affordability, because there's been so much rhetoric about what's going on with premiums, is not just your premium cost. It's your premium cost plus what do you have to pay out of pocket if you buy this policy. That's the equation. It's the whole picture that we need to look at, that total estimated cost figure that I mentioned before. So that we, because a cheap premium does not mean you're in good shape. It may mean you're underinsured, and I don't think that's the outcome that we're looking for. Remember that the purpose of health insurance is to distribute risk broadly. That's why we have this concept to begin with. So it is perfectly appropriate to have a standard benefit package so that we can distribute the costs of that standard benefit package over a broad pool. It makes it more fair to do that, but it also means that premiums are going to go up for some. As soon as you change how you distribute that risk, there's winners and losers. It's a mathematical certainty. And some people may not want to be the loser, but if they're not the loser, somebody else is. And so we need to remember that it's not like that everybody can be a winner. I'm putting tax credits aside for a moment. I'm just talking about what are the rules that govern how we distribute this risk, this giant pot of healthcare spending. And you have to make a decision about how are you going to distribute it, and you try to make it as fair as possible. And that's basically the exercise that the Affordable Care Act went through. That's why we have subsidies, because we want to distribute the risk broadly, we want to have a standard benefit package, but that's going to make it unaffordable for some. That's why you have the tax credits. That's why it's all one big package all together. The Affordable Care Act, I don't enumerate them today, actually includes a lot of pilots, demonstrations, activity designed to actually attack that underlying cost of healthcare. I'm not talking now about subsidizing health insurance premiums. I'm talking about what is driving healthcare at its core. The ordering of the lab tests, the unnecessary care that doesn't keep patients safe, et cetera, et cetera. There's actually quite a bit in the Affordable Care Act on that, but I would definitely agree that much more needs to be done. This is our huge policy problem, how much we actually spend on health care. Everybody is probably familiar with the Stephen Brill article in Time that caused such a sensation. The bitter pill article. Well, I just pulled out one little statistic that he included in this article. This is a drug that Flebogamma, if I hope I'm pronouncing it right. And he did a lot of work. It's not easy to get these types of numbers, but he did all this investigative work to try to get at it, just to illustrate the charge to the patient for this drug. And this is not the rack rate. This is what insurance actually paid. For one dose was $3,000. He estimated that the hospital, it only cost the hospital about $1,500. So, 100% markup there. But then, moving further down the line, that the cost to manufacture and ship this drug was probably something on the order of $350. So from here to here, this is one important element of why our costs are so high. Not every drug has this much profit taking, but there is quite a bit of this because the market basically does not work, and the market will not solve this problem. We can talk about that in the Q&A if you like. But this is the kind of thing that we need to get down. We need to understand how the money is flowing, and is it flowing fairly enough so that we can get the underlying cost of healthcare down. All right, so we're in North Carolina. I'm so happy to be here, and there's so much that you can do at the state level to improve things for consumers. The Affordable Care Act includes tremendous flexibility at the state level, and something that and if you've got folks who are talking about, we need to repeal and replace, if they've got a replacement option, they can do it right under the law that we have now. The key is that your replacement option must provide coverage to the same number of people as the Affordable Care Act. The coverage has to be just as good, and it can't cost anymore. So you gotta have a good replacement option, a real one. But there is a provision in the Affordable Care Act that says as of 2017, if you've got a better idea compared to the Affordable Care Act's idea of the marketplaces / exchanges, the tax credit subsidies, trying to leverage private health insurance, if you want to do something else, like Vermont's thinking single payer, or something else, you can do it. You have to get a waiver from HHS, and you've got to meet that criteria. It has to be just as good or better for your consumers is the bottom line. We have to get serious about health premium rate review. I think this is one of the ways, it's a feasible way to begin getting at healthcare costs. Rhode Island has got this, a lot of administrative leverage to really, basically they say, health plans, when you come in and you are trying to get us to bless your health premium rates, I want you to tell me what you're doing to make healthcare more affordable. They've really put the pressure on the plans to say, this is the point at which I want to know what you did when you negotiated with those doctors, those hospitals, to make healthcare more affordable. And we can use this at the state level to really start addressing those healthcare costs. And another thing that's going to tell you how the money flows is an all-payer claims data set, which is where private health plans, Medicare, Medicaid, all contribute contribute claims data to a giant database that, if set up properly, begins to tell us how is that money flowing, how can we tackle healthcare costs. This would be something I would highly recommend moving forward with.
Are both of those with the insurance commission?
A good way, this is set up in a lot of different ways in the states that have them, but I think a standalone entity, like a non-governmental entity, would be the way to go so that you can be more nimble and quick, but have a board including a variety of stakeholders. But the key, you can set this up a wide variety of ways, and I can provide some information about kind of what that scope is. The key is that you have to be able to work with the data. If you spend too much time actually protecting the data, then nobody's going to analyze it, nobody will ever see it, and you won't be armed with the information you need to attack the problem of healthcare costs.
In terms of the all-payer claims, do you think it's important to include Medicare data too?
Yes, I do. Medicare and private health insurance, the cost drivers are completely different between the two payment systems, but I think it tells you something about how care is delivered in your local community, so I would combine them if you can. I think it's, you might as well be armed with all the information. And then when providers talk about cost shifting and so on, you have some real information to respond to them.
And I understand that data has been very difficult to get from the feds about Medicare. Is it available now as a result of the ACA?
It's, yes and sort of. It is more available. They've loosened the strings for getting Medicare data, and states have successfully gotten it incorporated into their all-payer claims database. Part of it, and part of that was in the Affordable Care Act. It's probably still a bit of a rigmarole, but worth it. I mean, we're talking about 18% of your local economy here is tied up in healthcare spending flows, and it's time to understand where that money's going and how it's flowing. Good question. Okay, so I'm not going to leave you hanging though. We do have a little bit of information that might help you if you go out and work with consumers and want to get some of this information to them. I already showed you a picture of our tax credit brochure. That's the website to go and get it. We also have this interactive online tool called the Health Law Helper. This is, it includes information for everybody. It's free. We don't market to you. It's a pure do-gooder effort. And if you want to send people there to help them understand the Affordable Care Act and what it means for you personally, are you somebody who deserves Medicaid? You have an employer plan, but you don't really like it, and you're not really sure if maybe you could get something else. I mean, there's what we call 60 end-state scenarios in there designed to help people who face specific situations. And it's in Spanish, as you can see. And then this is that SBC, the summary benefits and coverage that I put up earlier. We have something that explains the explainer. Not a good sign when you have to explain the explainer. But it's kind of dense, I would love HHS to kind of take another crack at streamlining this. But it kind of tries to call out what the most important things are that consumers should look at within the form. And I think that's it.
We've got some time for questions.
To North Carolina, what coordination do you have with the state health information program? A lot of the older population, the website's irrelevant. They couldn't use it, couldn't figure it out to begin with, even if it worked.
The healthcare.gov.
Yes,
Yeah.
but in North Carolina, we have the state health information program where you can call, or they actually have offices where you can go in and talk to somebody. And what plan would be available, and that's been available, but I don't know that they have enough information knowledgeable about what the changes are gonna be going into effect.
And I don't know what they have either, Bob or Adam?
That's something you know about.
Yeah, there's actually a 800 number that I haven't memorized yet, amazingly, but and there's a system set up where you can make an appointment with a local navigator or person to help you select the plans in your area. That's very much like the SHIP program, but it's for sorting through these different plans. So if consumers call that 800 number,
Is that in addition to SHIP, or is that,
it's in addition to SHIP. Yeah, it's in addition.
seems like you're wasting then, why would it be, SHIP has provided a very good service that most people don't know about.
SHIP just does the Medicare plans.
Yes.
It's just strictly Medicare?
Just strictly for
The
Medicare.
scheduler is through legal aid and it's strictly for the ACA plans.
Okay.
So it's really two different.
But it's building on the SHIP model. People recognize how well that's worked, and so they're trying to actually sort of replicate the success of the SHIPs by having sources of information about the Affordable Care Act.
Well, the state was gonna set up a SHIP-like program for non-Medicare, but the legislation that the state passed prevented the state from doing that. So the Navigator program is outside of the state. It's different groups and organizations that have gotten grants and other things to do it on a private basis.
Right. So if Governor Pat McCrory and the North Carolina General Assembly had not sent back $74 million from the federal government in grant money that we had sitting in the bank, we would have a program that was integrated with SHIP. But I have that 800 number if people would like it. It's 1-855-733-3711. So 855-733-3711. And you can just call that and you will get an appointment with someone in your area.
Did you have a question?
I don't want to.
It's okay.
I work with the League of Women Voters, and we've had a statewide Speakers Bureau in the ACA, and we have a subgroup of CACs who are working and helping enroll people. And I have a background in insurance. One of the things that really concerns me is understanding how difficult it is to make a decision about health plans up front. That as we move forward and people do get enrolled, and they get their ID cards, and they start to get claims perhaps in the mail, et cetera, particularly for that population that has not been insured prior, their ability to manage the hassle factor of insurance is really limited. And I'm wondering if Consumers Union is thinking about how those people can be serviced effectively in the field after they're enrolled and after they are making their premium payments and things are sort of happening. Because we think about it in the private insurance world, our employers help us, right? We'll go to the HR department and say, I've got a problem with a claim, or we might have an insurance broker who can help us. But for these folks, the navigators, I don't think are going to be around. And I suspect even if they are, that's not going to be their job to help track down a claim payment kind of issue. So I'm just wondering if you guys have thought about that.
Well, we've begun to think about it. The issue you're describing is really important, and it's also a teachable moment. You know, like people would really prefer not to think about health insurance. I don't blame them. But when they're confronted with an EOB that they don't understand or an amount they have to pay that doesn't seem right, it's an ideal time to be able to go in and say, well, let me tell you a little bit more about health insurance works and what these terms mean. But who's doing that activity, which is your question. I don't know. I haven't seen the right model yet for that. I've been getting a lot of questions from reporters about what I call health insurance literacy, and everyone wants to know, like, how can we help consumers better understand health insurance? And that model for delivery is, we need to figure it out. Maybe the navigators there are these things called patient advocates, but I think they really take on the super complex cases, and maybe there's an intermediate ground there.
Other questions, if people may have.
You said you might circle back around to why the markets don't work in insurance, and maybe as a starting place, your Fleaba Gamma example. Why don't hospitals or individual areas as a group, have the wherewithal to negotiate a better price for the drug in the first place? I mean, it's gone from $350 to 1,500, so that's 4 full or 5 full, and then it gets double. And you know, you're kind of used to paying double for your dinner at a restaurant or double for a sweater at Joe's, well, some places. But you know, but you're, but that presumes that the wholesale price was paid for the good in the
Yes.
first place is reasonable. So if you've got a 4.5, 5-fold increase,
Mhm.
and then it gets double, you're screwed.
Well, so I think there's multiple things going on in our healthcare markets. Let's put health insurance aside for a second. Let's talk about the healthcare markets. First of all, healthcare, and I speak like an economist now, is not actually a commodity. It's not this interchangeable, one TV versus another, one car versus another, and it's not dispassionate. It's very emotional. Consumers, as soon as they have a diagnosis that is at all frightening to them, they want to defer to their providers. What do and they don't want to have to think about cost. And we have, this probably comports with your own experience, and there's also very good survey data and qualitative research that supports this. Their preference is, provider, you went to medical school, tell me what to do, I'll do it, and don't anybody think about the cost. And I don't blame them. I would respond the same way. So, to my mind, we really have to look at the providers and they say that the most expensive piece of medical equipment is the physician's pen, because that's not new. He or she is figuring out what this course of treatment is going to be. And if there is a lack of coordination and unnecessary tests are ordered, it's the providers that have to solve that problem, not the consumer. If they are not negotiating strenuously for a better price on drugs, that's the providers and the hospital administrators that have to solve that problem, not the consumer. So what's going on at this provider level that is failing to put pressure on prices? Because I'm sure everyone in this room knows we basically pay twice as much as any other country for healthcare that might even be marginally poorer than is delivered in other countries. And the one area where we don't do that is generic drugs, and that's because generic drugs are a commodity. It is something that people are very comfortable switching out one for the other. The prices are revealed, it kind of works. So a couple things are going on here. First of all, nobody really considers it their job to put pressure on prices. Physicians are there to help you get better. Hospitals are there to, facilitate that, to make all the numbers work. There's a lot of providers have, you can't have a lot of providers competing one against the other, particularly at the hospital level in most communities. So there's a single hospital that is maybe serving that community. And so they're kind of in a position of what's called monopoly power. That sounds sort of evil and bad, but it's the nature of this market. It is, it is something that can't be delivered by multiple hospitals all at the same time, because while that might create a competitive environment, even though it probably wouldn't, it would also cost too much. It would be duplicative services that we don't need. So there's a lot of things going on that fail to close the loop in terms of having a fully functioning market. And I think that's why we really actually need this all-payer claims data set approach to sort of look and see how is that money flowing. Because the market, left to its own devices, as we've seen for the past 30 years, is not going to do it on its own. There has to be some oversight, some surfacing of data that we don't see now to figure out what's really going on there and where do we have to make some changes. I don't know if that responds.
Yeah, it does, but if I may follow up, and I don't want to hog the floor, so this will be the last question. There are plenty of people in the world, and Ryan and Chris were referring, and Adam all referred to someone on the conservative spectrum, who insist that there is a market solution to this. And so, can you play devil's advocate for a minute and explain what that solution is supposed to be? What's the market here for,
Mm-hmm.
what I've always believed or been taught was a market failure?
Yeah. So I would, channeling my inner conservative here, which doesn't really exist, but because you probably figured that out, so this is not a big secret. I think that the mechanism that they're hoping is by giving consumers skin in the game, I hate that expression, but by making sure that everybody has to have some ownership of the spending, that will put pressure on insurance companies to then negotiate aggressively with providers who will then keep costs down. I think that's the theory of how it's all supposed to work. And it breaks down at every level. The majority of our spending, 70% of our healthcare spending is concentrated in 10% of the population. That 10% of the population met their out-of-pocket cap a long time ago. I mean, there's just no way we can keep charging them for this healthcare that they need. There has to be a limit because nobody can afford the full cost of healthcare. We already talked about that. So it breaks down at the consumer level. It also breaks down at the consumer level. I know you'd asked me to, I'm done channeling my inner consumer.
Yeah, you are.
It is. It also, and as I explained before, when consumers reach a certain point in their treatment, they don't want to be the ones in charge of the dollars. They want to be in charge of getting themselves well, and I don't blame them. And then at the provider level, well, at the health insurance level, health insurers just pass the money back and forth. They actually, forgive me if there's any health plans in the world, they're not very good at keeping healthcare costs down. In part because if there's only one hospital in town, that hospital is going to be in the network. Otherwise, nobody will buy their plan. So they're not in a good negotiating position vis-a-vis most providers. They are in a good negotiating position vis-a-vis our primary care physicians, which is why they're paid the least, because they're small, they're small groups. But in terms of where all the dollars are being spent, health plans are in a poor negotiating position. The market power is with these specialists, with the hospitals, and that's where we have to sort of focus our energy to getting healthcare costs down. And those folks, they pass it down. The hospital says, well, Dr. Smith, who's very eminent, he wants medical device A, we're going to get it for him. But Dr. Jones, he likes medical device B, we're going to get that for him too. We want our physicians to be happy. And so, they just pay full freight for the medical devices, even though, there's just very little negotiating at that point. So.
Okay, thanks.
There's a question over there, sir.
You have an excellent presentation, thank you very much. But it is still on the technical level. Can I ask you one or two philosophical questions in the whole thing?
Yeah, I'll try.
Given the fact there are roughly 30 countries that have healthcare plans, none of them are market-based. None. In various forms, what makes you all, I'm going to assume you all are born Americans, not be able to make that jump? The fact that when you all walk out, one of us will be sick. All of us will be sick eventually. Pardon me my saying so, you all die. It's a very normal thing. And as you may hear, I come from another part. Your northern European countries do not run socialistic systems. That's long past. They run systems that are like the farmer that has cows, and the cows better be healthy so they can get milk. People have to work, they have to pay taxes. It's a very simple equation. Germany started that in around 1950. And so, what makes this so difficult?
That's why our ancestors left Germany. We want kings and queens making our decisions, and that's our brilliance and also our inability to come to grips with these social things. We want to make it still.
Let's let Lynn answer the question.
Well, I think there's probably multiple answers. I would agree with yours. We have these preconceived notions about how goods are supposed to be delivered, which is, I did in my defense, I did talk about it being a social good at the beginning as opposed to a commodity. I think we're going to get there, but very, very, very slowly. Very slowly. And I don't think it's a philosophical problem. I do think it's a bit of an ideological problem.
But this example you have with this drug is a normal market-based way you price out a hamburger. You start with extremely low cost. I mean, anyone's per pound they have on cost, what is it? Less than $1 when it's made over there in Bangladesh. It's a bit unpleasant area that they make it, but that's all it is. By the time it's sold by dealers, it's going to be at that level. It's a normal thing, but do you do that? What makes it that people want to think that healthcare has anything to do with goods and services? There's nothing. It's a forced economy. Yeah, you will be sick, unfortunately.
Yes, I agree.
And as someone who is in Medicare, we do push the doctors on pill costs, on Medicare costs.
Mm-hmm.
It's a constant struggle.
We have a question right here in the front.
Well, it's more of a comment that, for instance, I have this friend that's in this exchange that already exists here because she's uninsurable on the private market.
Mhm.
She's
Yes.
self-employed, she has diabetes, type 1, blah, blah, blah. And when you go and you look at her choice, and I looked this up in other states as well, her choice of coverage that she can get is almost a monopoly in the whole United States when you go state by state.
Yeah.
There's maybe 3 usually that cover the whole market. Say Blue Cross Blue Shield may cover 70% of the people covered. So the idea that there's a market, a fair market in which you have choice pre-ACA is kind of a fiction, and I don't ever hear that brought up, that your choice, if you were in between Medicaid, you couldn't get Medicaid, you weren't old enough for Medicare, you weren't covered by an employer, that, you know, your marketplace before all this happened was pretty narrow.
Absolutely.
Or
It-
not.
The more rural your state, the less likely you are to have a choice of providers in the non-group market or the market where you buy on your own. In fact, there's almost no markets that are truly competitive with respect to health insurance providers. You know, maybe some in California, maybe some around New York City, maybe the DC area. You have to have a very dense population to be able to support multiple insurance providers, because an insurance provider has to deliver a certain volume of patients to hospitals in order to get them in the network and be able to negotiate. And all those conditions that need to be present there's very few areas of the country where they're present. So I would agree with you. I'll try to bring that up in my talks.
Dick, and that's
I've heard that the Affordable Care Act is somewhat similar to the German system, which I understand the German system uses the insurance companies to keep the costs of healthcare down. And if it's working in Germany, how come it's not going to work here?
I think that the German system, and I'm not an expert, so if I don't quote me on this, but I think that it is similar in that they use private insurance companies, but I think that the prices are regulated to a much greater degree. Here we don't actually regulate the prices, the underlying prices that can be charged, and I think that's the difference, because Germany delivers healthcare much more cheaply.
Yes.
Senator Wood, did you have a question?
Kentucky, a smaller state, more rural than us, has I think 4 or 5 in their marketplace. I can understand why Texas has 8, California has 11 or 12 or whatever, but I'm not able to really answer when people ask me the question, well gosh, my relative in Kentucky's choosing between 4 or 5.
Good
Right.
question.
Well, I think one thing is that it's partly a historical artifact. I mean, your dominant carrier is the Blues carrier. And, you know, Blues plans originally came in to be the carrier of last resort, maybe a community-based, you know, what's the word I want? A provider who, you know, nobody could be turned down, and and so they grew to be very large carriers. Anybody can.
It's a nonprofit.
Yeah, right. So, you're right. I mean, and it was all sort of good and cozy before healthcare costs, you know, started their huge upward climb. So you've inherited this dominant carrier, and it's very, very hard for new carriers to break into a market. It's all but impossible. So a lot of this is sort of a historical artifact as to what was going on in the states, in a given state, like 30 years ago. So that would be my answer. I don't know if anybody else has a
A sort of related topic. Could you comment on how North Carolina's decision not to expand Medicaid plays into this whole conversation that we're having right now?
Yes. Well, so it leaves a group of North Carolinians uninsured. If you are not eligible for Medicaid under one of the categorically eligible populations, you're a child, you're disabled, etc., but maybe you're a childless adult, maybe you're working, but your income is under poverty, you don't have a coverage option because when the act was passed, it was contemplated that every single state would expand Medicaid. The Supreme Court said, no, it's state's option as to whether or not you expand Medicaid, which may have been the right decision legally, but it's a problem in terms of trying to get everyone into coverage. So there's a large group, I think in my earlier slide, there's about 500,000 that will not have a coverage option without the Medicaid expansion.
So how does that affect Blue Cross Blue Shield being maintaining such a dominance? Is this part of this conversation or entirely separate?
Well, it depends. I don't know, and sorry, I'm going to have to turn to Adam again. I don't know what types of providers the Medicaid program uses here. Is Blue Cross Blue Shield of North Carolina also the Medicaid provider? No, different provider? No. So I think it's going to be separate then, because Medicaid, each state has its own way of contracting with providers to deliver the coverage, and it sounds like it's a different entity. So it sounds like for Blue Cross Blue Shield of North Carolina, it is, it's really the population in poverty and above. Now, if North Carolina were to expand Medicaid above the poverty line, now there's a group in overlap, and you are starting to affect Blue Cross Blue Shield of North Carolina. But I assume that's an even longer shot than.
I mean, the other thing would be the state that, since we didn't do a state exchange, that made it more reluctant for some of Blue Cross's other competitors to be in. So, United, we probably would have had one or two other insurers in the exchange if the state had done it.
And just in case anybody doesn't know this, I mean, I can't speak too politically as to what's possible, but you can still set up a state exchange at any point in the future, and the grant funding to establish these is still available. Right now, it's just available for this calendar year, but it's not like the option has been cut off forever, just so you know.
There's still hope. Senator, another question?
Well, a comment to the question about the League of Women Voters, and I don't know what the Justice Center staff is finding, but I'm finding that at least the rural counties I represent, that the community health centers have been incredibly helpful moving forward. And in my conversations with some of them, they're trying to find how they could be the solution to how do we move forward, how do we help people once they're enrolled and insured. Which I would make an argument is why we need to be very careful about how we mess up Medicaid. But anyway, that's a topic for another day, I guess.
And one of the things that's a really helpful tool is to have a list of those federally qualified health centers and other safety net providers for those folks who do fall in this gap where they don't have any coverage. And those are very robust options for people, actually.
Yeah, and they've been, at least in my district, they've been great. And I had a story similar to Adam's on Saturday. It was a rural church in southern Castle County. We had about 45 people come for a session, and the folks from Piedmont Health, the Prospect Hill Center, came over, and we just heard a very compelling story about a young mother who had gotten insurance for the first time for her and her 3-year-old daughter. So I was pretty moved, Adam. I share your experience with that. Also, our departments of social services at the county level are also beginning to have conversations about what role they're going to be able to play. Again, it's going to be a burden and a stretch on them at a time when their funding is tight, but at least again with the DSS directors I've been talking to, they feel compelled to sort of fill some of that void. So hopefully we won't mess up our community health centers, and our DSS departments can help us out there. So at least those are some options, when you're talking with folks.
Yeah, health plans are required to include the community health centers in their provider network. So, because you're right on the money, that's the low-cost provider that we want to be empowering.
Yeah.
But,
any last questions
If they
or
don't
comments?
mess up Medicaid.
Well, if not, join me in thanking Lynn for coming all the way. To be available on our website probably by tomorrow. So if you want to share it with friends and colleagues and who weren't perhaps able to be here today, and tell them about this presentation, do check us out at ncpolicywatch.com. We'll be scheduling some more crucial conversations coming up in January. Hope you all have a happy holiday season. Check us out on the web. We'll have some interesting lists at the end of the year of the top 10 lists of various ilks on the website, so check that out. And we'll see you next time. Thanks for coming.